Welcome. Good morning, and welcome to the Health Leaders AI Now Online Summit. My name is Eric Wicklund. I'm the Senior Editor for Innovation Technology here at Health Leaders, and I'm going to serve as the moderator for today's event. And this event consists of two very intriguing panel discussions. Over the next couple hours, we'll be bringing you thoughtful, insightful, and engaging content that will explore key areas that will be critical for the current and future success of your organization. Kicking off our event this morning is the opening panel session titled Taking Agentic AI to the Next Level. Thank you to our audience for joining us today. Before we get started, I do have a few housekeeping details. This program is going to be 60 minutes in length, and it's going to be a hard 60 minutes because we do have another panel right after this one. Note that there is an on-demand version of this program, and it'll be available approximately one day after the completion of this event. And it can be accessed using the same login that you used for this live program. To ensure that you see all the content for this event, please maximize your event window and be sure to adjust your computer volume settings and or PC speakers for optimal sound quality. Next, you'll find a resources list for today's webinar in the upper right corner of your screen. Here we've listed the slide deck along with the supplemental resources that you can interact with. Move up, here we go. At the bottom of your console are multiple widgets that you can use to submit a question, and we will have a Q&A session at the tail end of this hour, last 10 minutes or so. To submit a question for that Q&A session, click on the Q&A widget. It may be open already and appear on the left side of your screen. You can submit questions at any time during this presentation. However, please note that they'll be answered. We'll get to as many of them as we can at the Q&A session at the end of this program. Finally, should you experience any technical difficulties, and we all have that happen, during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. At this time, it is my pleasure to introduce our three panelists for today's discussion. I have Jim Blum, Chief Health Information Officer at the University of Iowa Healthcare. I've got Zafar Chaudry, Senior Vice President, Chief Digital, Chief AI, and Chief Information Officer at Seattle Children's, and Byron Yount, Chief Data and AI Officer at Mercy. And you'll notice right now we're having a little bit of technical difficulties, so you might only see a couple of the panelists, not all three, as we move forward. Thank you all for joining this morning. And with that, let's get to the discussion. And question one gives me a chance to ask or to have each of my panelists talk about themselves a little bit. Tell us a little bit about yourselves and organization, and maybe you can throw in, an idea of how important, what your AI strategy is right now. I know we'll get into that later, and I don't want to spend too much time going through the introductions and all, but just if you want. Let's start with Jim.
Eric, thanks. It's good to be with you today. I'm Jim Blum. I'm the Chief Health Information Officer at the University of Iowa. My background is prior to med school, I trained as a computer scientist in the era when neural networks were hocus pocus and a fool's errand. You can see where that went. My background in medicine is I'm an anesthesiologist and ICU doc. I also have an aerospace medicine practice. I continue to practice, but I also really lead our clinical AI strategy here at the University of Iowa. Our approach to AI from the very beginning has been treating it as an additional IT tool, looking for problems that we need to solve. So just as we would look to a revenue cycle tool to solve a revenue cycle problem that may incorporate AI, we look for tools that will help us solve problems, either those that we build internally or that we go out and procure, to solve a problem that we're trying to address that enables our team to take better care of patients at the end of the day. And so right now, our focus, I think, as many organizations, has been really on ambient, but we have started to really move into other agentic domains fairly rapidly, in addition to a fairly large predictive analytics domain that we're growing to help drive care.
Okay, thank you. Zafar, you're next on this.
Good morning, everyone. A pleasure to be here. I'm Zafar Chaudry. I'm the Chief Digital AI and Information Officer over here at Seattle Children's Pediatric Health System. We cover Washington, Alaska, Montana, and Idaho. And my role is not to also run the day-to-day lights on, doors open IT function, but also the digital health and now the AI stack that we have at Children's. And certainly in my world, we don't just look at AI as a shiny new toy. We look at it as a way to return the human to healthcare by stripping away the admin friction that burns out our best people. And to achieve that, we have multiple AI models running. We use the Google Cloud platform for all of our analytics. Vertex AI, Gemini AI, and we have multiple admin models, multiple clinical models running, and agentic AI models. And everything we build is built on what our parents, patients, caregivers, clinicians require us to build to solve particular use cases. And we've been doing this since late 2022.
Okay, thank you. And last but not least, Byron.
Thank you, Eric, and thank you, guys. Can everyone hear me?
Yes.
Just want to verify, thank you. So Byron Yount, as you mentioned, and I serve Mercy as our Chief Data and AI Officer and have roles in transformation, given that AI is at the seat of a lot of transformation in healthcare, and then also in partnerships. Mercy is a healthcare integrated delivery network and system in the Midwest. We cover states of Missouri, Arkansas, Kansas, and Oklahoma with really good density with not only hospitals and critical access facilities for a lot of urban and rural spread, but thousands of clinics and integrated providers. So real dense in the areas that we serve. Also have a strong presence in virtual care. Generally, our strategy is not that differentiated from the way that the gentleman mentioned. We operate in what I call our 6 strategic imperatives for AI, and that is assuring that our AI is grounded in our mission ethics and our responsible AI program. We've built up a data advantage, really a number of years, having been on electronic health records for a very long time now. One of the oldest. We venture to maintain and expand our flexible AI architecture underneath, because we do a fair amount of building within the system. I helped put our first model in place about 12 years ago now. Training and recruiting our world-class caregivers in AI, because it's going to be part of their day-to-day if it isn't already. Growth in our strategic partnerships within the spaces of data and AI. And then, of course, capped at the very end, it's important to solve real problems. That's how you build and earn trust and get to come back to do it again tomorrow.
Okay, very good. Thank you. Let's get into the fun stuff now. The topic, of course, is agentic AI. And I know I've talked to each of you separately about some of your programs, and I want to start with Zafar on this one. What agentic AI tools specifically are you developing or using for clinical care?
So our biggest use case is a tool that we call Pathway Assistant. And what we've done, so Seattle Children's over the last 30 plus years have been building clinical pathways for care for pediatric patients. And those pathways have culminated into probably 6,000 or 7,000 pages of PDFs, which our clinicians use and our trainees use to treat the most common conditions in pediatrics. And we freely give away our pathways, and they are used all over the world. Now, that's not really the most efficient way to find out how to treat someone, especially in a crisis. So we took all of our pathways and we fed them into an AI agent and created Pathway Assistant. And that agent now can interact with the clinician. Clinician can ask questions, can feed in information about their patient. the age, the weight, the symptoms, and then the agent will start interacting with the clinician by asking the clinician further questions, probing deeply, asking the clinician to go away and do certain tests, building a differential diagnosis stack, at which point it's great for trainees, but it's also great to get to the answers very, very quickly. And that took about 50 physicians, 100 hours each to help build, train, test, and launch that agentic AI model that's now in production. So it's been very successful and certainly makes people happier when they don't have to troll through PDFs.
Nice. Okay. Yeah, it's kind of the modern version of clinical decision support. I do like that you've developed it in-house too, which is one of the bigger questions that we're going to get to later is the idea of building in-house or going to a vendor and getting their tool. There are two different strategies and some very interesting projects coming out of this. Byron, how is Mercy using agentic AI in clinical care now?
A few different ways. It was mentioned a little bit earlier. There's still a double bind for clinicians in healthcare and the need to document and do ever more documentation as well as increase labor productivity. So we make good use of ambient technologies and the workflows that are becoming increasingly more agentic within them. We have DAX as a system if we're naming names. And have scaled that across our primary care providers going into inpatient and out to nursing as well. We use also an image overreader, right, to look at images, currently CTs, X-rays, mammograms, looking for findings. There is a workflow associated with that allows us to understand the priority that's being picked up by the AI, and that's certainly improved our turnaround time. And there's more workflow and agentic, kind of coming out of this particular vendor that we're working with. And then we've done in-house development as well, probably somewhat similar to the care pathways that was just mentioned. We began pretty early on in generative AI, really about 2 years ago, building and putting our first system into place in the transitions of care. That's an area in healthcare where there's a lot of handoff. There can be a lot of drops and errors. And so, but it's also a space where a lot of information needs to be moved from one care team to the next because the care team doesn't move with the patient throughout the system, either going from the emergency department to the floor to the home, or whatever it might be. So we've built agentic systems that takes a lot of the information that's being collected on the patient, both during that encounter as well as historically, and create the standard handoffs that are needed, really to the gold standard, and ensure that happens each time. So to date, we've processed now millions of these handoffs to help with the transitions, which is, improves the time that it takes for that kind of documentation and handoff to occur. It drops it significantly. But we've also noticed that there's been improvements overall in satisfaction, as well as some signals that we think are associated with not only the tool, but the work that we've done on the surrounding workflows that lead into that tool and exit out of it, that leads in to improvements in care and clinical care. So those are some of the areas that we've worked in the clinical space, keeping you firmly on the loop, because at the end of the day, they're the ones responsible for the medical record.
Thank you. Thank you, Byron. Yeah, two different use cases right now for AI, for agentic AI. This is interesting. Now, Jim, we've had these discussions before in the AI and Clinical Care Mastermind program that you've been part of with HealthLeaders. Tell us a little bit, and University of Iowa Healthcare, you've kind of been one of the front runners in this, doing it for a while now. So,
Yeah.
How are you developing and using agentic AI?
Yeah, so I think the agentic domain is an interesting one. How do you actually have AI become actionable, right? Rather than it just creating documentation for you. So we're very early into the ambient domain, but at the same time that we acquired that technology, we use Nabla. We've been very happy with it. We acquired another platform for AI that at the time was designed for what we term clinical data intelligence, that would help surface information about patients. It's a tool that's called Evidently. And that was very helpful in that it would aggregate information across the entire platform, whether it was stuck in a PDF, whether it was an image, whether it was something that was in our native EHR or in one of the HIEs. It would bring all that together into a comprehensive picture regarding a patient, and display that information in a very usable format for our clinicians. But since then, they put an overlay of a large language model on top of the knowledge graph that they develop regarding each patient. And what that has enabled us to do is to really start to move into the agentic domain using these types of technologies. And so at this point, we have a variety of things, that, some of which I would say are approaching true moving out of beta into actual production. But everything from VAD workups or ventricular assist device or transplant workups and dramatically reducing the time and actually being able to grade some of the data that we have and find where there may be gaps. Work that would previously take 20 or 30 hours, we can condense into a 1 hour meeting, right? And present that type of information to our providers. That's not just, here's a summary, but actually here are the missing elements that you need to complete this evaluation, right? And actually potentially providing some great elements of concern, right? And that is a huge advance for us as an organization, bringing that forward. And when you look at where you can apply sort of that logic and intelligence across the system, that falls into obviously things like prior auth and denials and all those types of things that are more back office things. But in terms of actually delivering care, can we actually develop technologies that are high enough quality that, for example, the plan of care can be drafted, right, for a practitioner to then review, as opposed to natively drafting things. And some of that comes from pathways, some of that may come from actual knowledge. Can we move to that domain? So that's where we're starting to experiment at this point. And those types of things where we're coming up with care plans is clearly in the experimental domain and something we're thinking about. I think in terms of agentic, the other area that we've seen, and it's not necessarily clinical, but the back office has just been transformed very, very rapidly. And it has profound impact on our clinicians. So the thing I'm most excited about this year is we're going to try to truly move our coding to be automated in our ambulatory space. And then in 2027, hopefully move it into our inpatient space. And we've partnered with Codemetrics to do that. But if I can remove charge capture and much of the coding identification that is placed on the shoulders of our clinicians today, between our ambient documentation, our support for presentation of that data, whatever that might be, to help prevent people from having to dig through charts and remove the coding burden, I think then we will really provide an ideal environment for people to practice, and really make it the way medicine was, prior to the EHR, where people could scribble some things on a piece of paper and move on to the next patient, and provide the care they wanted, which is why they went into medicine to begin with. We jokingly say no one went into medicine to type and do documentation. And we're trying to limit. I think with these technologies, we'll truly get to that point in the next couple of years.
Yeah, It's an interesting integration too, as my colleague Luke Gale has found in revenue cycle management. That seemed to have been the early successes with AI. A lot of low-hanging fruit in administrative tasks there that AI was able to really have an impact with. And now, as you're saying, there's kind of a movement from rev cycle management to clinical care, and kind of putting those two services together. And help, as you say, helping clinicians with some of these back office things that they need to do.
If you talk to a clinician, the thing they absolutely hate most is dealing with some administrative back office thing, right? Yep. And so if we can remove that from their day, that is probably one of the biggest wins that we can possibly deliver to them.
Yeah. Okay, let's talk. Okay, we've talked about some really good use cases. Here's some really good examples. I'm going to stay with you on this one, Jim. What are the biggest challenges to using the technology right now?
Yeah, I think particularly in clinical care, as we start to move into the decision support realm, strongly into the decision support realm, not just surfacing information for folks, but you start to have recommendations made by these systems, it's going to be safety, right? By default, large language models are going to, by definition, they are going to, at points, give you incorrect information. And I think that if you look at the current set of models that people are using to do these things, I mean, most of these platforms are going out and they're using some derivation of one of the big three, kind of three or four AI vendors, right, to deliver these technologies. And they're mostly using large language models. That is going to be a big problem, right? Is validating safety. And so how do you do that? What defines safety? What are the human interventions that need to be, what are the human breaks that need to be built into Agentic? Is going to be a real significant concern going forward in the next 3 to 5 years. I am optimistic, although I should say cautiously optimistic, that new forms of AI, in particular world models or things that are trained more on events rather than tokenized words, are going to help us address some of those concerns. But I say I'm cautiously optimistic because I do think that we may lack the features, and there's a lot of things that happen in medicine that are just so stochastic that it gets very difficult for us to potentially develop good models for those types of events. And so we'll see how it plays out. It's a very exciting time, but I think that's the biggest concern that we have going forward overall, which is how do we make these things safe to actually truly make them agentic and automate care where we can.
Okay, Zafar, I'm going to ask you the same question. What are the challenges you've seen so far in using the tech?
So I think the tech is really the easy part. Mm-hmm. The harder parts are probably trust. If the agent or AI makes a recommendation, you really need to know if it's accurate and is it safe. Then we have integration. If it doesn't live inside the native workflow, like an Epic or a Cerner or a Meditech, then clinicians will probably not use it if they have to log into a separate application. And then thirdly, I would say liability. Who is responsible when an AI or an AI agent misses something? I don't think the legal framework is there yet. It's still trying to catch up to the code. So those would be the 3 areas I would say are the biggest challenges.
Yes, okay. Yeah, and if anyone here has watched the HBO series The Pit, last week they introduced Agentic, or they introduced Ambient AI, a dictation tool, and that was the problem. It added a diagnosis into the medical record that it was being dictated. There's certainly an issue is that you need to trust the data. Byron, same question for you. What are the challenges you're seeing in integrating AI?
Yeah, I think that I won't repeat what was stated already, though I agree with them. I'll go into the spaces where I I think we've hopefully matured past, but I still see happening across healthcare. And that's generally with Agentic. It's true for AI, of course, and almost everything, is that you got to solve the right problem or the opportunity in the first place. But now when you're going to be automating and using Agentic, you're encompassing entire workflows, right? It's not just a solution you're working on. It's often an entire workflow, and you can build something that creates a bottleneck and a problem somewhere else in your system. So it's being very thoughtful up front, whether you're building or you're buying, that you build and you buy the right thing. Because, there's a cost to everything, and then there's a cost of also goodwill if you choose incorrectly. I think the guardrails piece was mentioned, right? Making sure that you've got the guardrails in place, how decision rights work, where the accountability boundaries are, how you escalate, how you report events, the oversight structures, all that needs to be thought out in advance. And then the other assumption I think that's made a lot is that things will scale in sort of a linear fashion. And in truth, especially in complex workflows, unless you've got a lot of already standardization in place, you're solving for a complexity each time you move into a new context, a new space, and especially if you're trying to connect one agent and one workflow with another. And ideally, that's the space that you're getting into, so you create some reusability of some of the information assets that you're building. But these are all maturity factors that I see out there that people learn through. They sound simple, but you got to experience them in some ways to get really good at them and be quick.
Yeah, and we're still in the early stages of AI development, especially in clinical care. It's interesting to see how this evolves. All right, here's a good question, and I'm going to stay with you, Byron, on this to begin with. The idea of using data, of data governance, data management. AI requires data. It continuously requires data to improve. How do you manage and protect the data, especially the personally identifiable data that you use for these agentic AI tools?
Yeah, I think it's a good topic. For us, I think it's trying not to overcomplicate things. So we've incorporated AI governance into our data governance model, and just to simply call it now responsible data and AI as a connection point. So we're reusing a lot of the same governance structures, and we already have established policies when it comes to data governance, privacy, security, compliance protocols. You do typical things, especially if you're developing data segmentation and access controls, through role-based, for example, environment segmentation. If you're doing development testing, production splits, make sure that you're putting controls in place for PHI. More and more, because AI is scanning entire stores of information across your system, need to have good detection in place for PHI and PII. It can make it outside of the normal places, and so you want to be able to scan that so you're not assuming it or ingesting it at all with the AI that you're running. We go through a lot of solution reviews, so solution and model risk oversight, it's a critical function. All these solutions undergo our comprehensive security review, solution architecture review, contractual controls that you'll put in place, including BAAs, data use boundaries before you actually begin deployment, for example. And then just having a responsible, sort of AI audit, model cards, registration, all of this in place, and then observability, making sure that you can trace and audit what is happening across the system. That's going to become a requirement, right, if it's not already by your own standards. So that observability is kind of fundamental to understand what's happening to data and understand how you're protecting it within the system.
Okay. Jim, same question. How do you manage data and how do you protect PHI?
Yeah, so internally we've had this, we've all had this problem for the better part of 2 decades now. I think the big concern that we have with AI is how is the data being used to train models, in particular large language models, and potentially world models as it goes out into our vendors' hands. And our solution to that has just been, in addition to meeting all the security requirements that you have to have a BAA with us, you just can't train on our data, period. That is our solution. We do not believe that you can truly de-identify to the point that, particularly with large language model, you will not have PHI embedded in some, or I shouldn't say PHI, but identifiable information embedded into an LLM. And that was a major point of contention with many of our vendors when we first started down our AI journey in 2022, 2023. I think that is, looks like we lost Eric.
Oh, no, I'm here. Sorry.
Okay, there you go. Yep. I would say that was a major problem for us, but we found vendors that are willing to work with us and cooperate, those types of things. I do think that this is a big problem because to make these models better, you need to have folks that are going to cooperate and be willing to let you train. I think it's just been we treat our patients' data as incredibly sensitive, and we're not willing to share genomic data, for example, with some of the larger registries because of the concerns about identification, re-identification later. And we may take it to an extreme, but that's our institutional policy, and I think that's what we've been dealing with.
It creates some interesting dynamics between the health system and the vendors that you use for AI.
Yeah, and there have been folks where we had to say, sorry, we just, we're going to have to agree that we aren't going to be able to do business right now. So. Yeah.
Zafar, same question. I know you had developed a tool in-house to use your own data to make sure that it was just your data and that you were using it. How do you manage and protect data for AI?
Yeah, so I certainly concur with what's already been stated. I would add that we try to use zero retention policies for our tools, so that if something is generated, it's then deleted and not stored for a period of time. The other thing I'll highlight is hosting. We try to make sure that when we run models, we try to run models in secure cloud or private cloud environments so that information doesn't leave our perimeter. And of course, you do need to try your best to de-identify and strip PHI if you can. It's not always immediately possible, but if you can, to do that. And storing information within models for long periods of time is probably not a good idea unless you know exactly where that model sits and you have some form of control. Those are some of the additional things that we've tried to do. I don't think there's a perfect solution to this. I think you are taking a level risk. You do try to cover that liability through BAA agreements with vendor partners. But what I find really interesting in this journey is even though all these vendors are touting that AI is going to save the planet, what's really interesting is that they don't want to own any of the liability. I mean, even the biggest companies won't sign for more than $2 million in liability. And the challenge being, if a patient is harmed, you can bet your bottom dollar that the legal costs will be more than $2 million in liability. And so I always argue that if you truly believe that AI is going to save us, then why won't you put your money where your mouth is? And they don't want to do that. So that's the rhetoric of what I'm seeing with AI.
Yeah, and we haven't seen that court case yet, that high-profile court case that's really going to affect how data is managed in AI tools. Everybody's waiting for that first test. It's going to be interesting when it happens. Okay, let's get away a little bit with the challenges, and go back to how that these tools are working for you, that these really are making a difference. And I'm going to stay with you, Zafar, on this. How do you know that your agentic AI tools are giving you the ROI? And there's that phrase that everybody wants to talk about. They're giving you that ROI that's going to please your clinicians, that's going to please your CFO.
Yeah, and I think that's the rabbit that we're all chasing, right? Because we'll have AI, and will AI eliminate, X number of FTEs? It's the dream that everybody's living. And the way we look at it is, we don't just look at, does it work? We look at some of the other benefits, like time savings. Is it helping clinicians with burnout? Are they finishing their charts and avoiding that dreaded pajama time that we tend to see in the clinical space? We do try to look at tools that we built, and are they actually impacting clinical outcomes? Are we affecting length of stay or readmission rates? If we're using admin tools, certainly people are using these AI tools to fight pre-authorization or denial of pre-authorization from the insurance companies. I would argue, good versus evil AI seems to be in place. And so we can measure that based on the success that we have. But I do think it's rhetoric when people think that AI is just going to clearly eliminate people. I think it is a tool on a tool belt. It's going to help our clinical teams focus on what they wanted to do in the first place, which was take care of patients and not sit at a desk and type away forever, so that they can meet an insurance claim. So I think it's just an additional tool. We haven't seen financial savings where we could just clearly say we can eliminate people because of the tools, but we have seen improvements in burnout rates. We have seen clinicians be much happier, especially with the ambient AI type tools, right? They get to spend more time with the patient. Amazingly, some people can go home on time, which is a huge win. And they're not working through the weekend trying to catch up on the clinical documentation, as an example.
Nice. Okay. I just wanted to mention, we are past the half-hour mark on this, and the time is flying. Anybody who wants to submit a question for the Q&A, please note that we're going to get to that pretty soon. We do have a few questions in here that I'm going to try to work into the conversation. Now let's go back to the ROI of agentic AI. Byron, how do you measure ROI?
I think it's not only tool specific, right, or workflow specific. It's persona based, and that's probably obvious as well. So it depends on who. It's the patients, right? We're looking generally at satisfaction. Have we caused them less grief, right? For example, reduce the denial rate. Have we, improved the life of a clinician? At least in our ambient, we know that we're seeing on average one more patient, per day, per clinician, right? That we recorded 22% lower cognitive workload. At least that's a self-report. Cut down on charting time by up to 77%. And we know this because we track it, right? So increases in provider satisfaction. So it's definitely there. There's value. And sometimes there's not. You have to be willing to turn things off when the value just isn't there for you, or something better comes along, quite frankly. Impact tracking is important. So the value tracking over time, you've probably heard of model drift. You can have impact drift with the models as well. So it's important to measure it. We've gone more to value-based contracting, believe it or not. There are partners that will go to that with you. And in that case, it's a forcing function. You have to be really good at measuring value capture, value return, being able to attest to it, because that's how the partnerships are aligned and how you exchange, goods for service or money for the services that are being provided, or in many cases, things that you're developing together. So we've definitely seen it in back office. Certainly other types of value being expressed on the clinical front. Anytime we think we found something that we otherwise would have missed, that's a win, obviously, for the patient and for just medicine in general. But it is very much solution-specific, persona-specific, so we try to have our framework follow a persona-specific framework.
It brings to mind the question, is there anything that has surprised you? Have you found an unexpected benefit or value to your AI tools?
I can go first here. And this was really apparent in our first one. And it was because generative AI is so new, people will watch it so closely, and it becomes a great mirror back to the organization. So the questions become, if what I'm seeing a cause of the AI, or is what am I seeing is a cause of, let's say, information flowing into the AI system? And oftentimes you'll find that you're able to make improvements elsewhere, just because it's showing up as artifact or some perceived error issue with the AI itself, when it's actually not specifically the AI, hallucinating or doing something. It's something else that's fed into it. So that's a benefit. And then it's always exciting when you can find ways to reuse and connect things together. That's another big impact we seek, but don't always assume.
Great, thanks. Jim, same question. How do you measure the effectiveness of these tools? And added on to that, is there anything there that has surprised you about about the benefits?
Yeah, so I think the ROI is always a concerning question. Although to some extent, I think that the ROI with some of these tools has become moot. I would challenge any health system to say right now, we're not going to. If you look at the data on ambient, right, it definitely makes providers happier, reduces, after hours work somewhat, probably not as much as everyone had thought, increases productivity, maybe a little bit in clinics. I would challenge any health system to say right now, we haven't determined the ROI that we thought we were going to see that was originally touted by the vendors of, you're going to see 20% more patients a day because of this. And we didn't see that, so we're going to get rid of it, right? And they would summarily see all their physicians and medical staff disappear as well, right? So to some extent, this has become table stakes for some of these technologies. I definitely agree that back office, the ROI is clear, right? With some of these coding tools and clinical data intelligence tools, with boosts in CDI and MCC and HCC and CC capture, the ROI is clear, and you will see that in moments. And again, that's becoming table stakes for an organization right now, because you have to provide those tools just to maximize whatever you can get out of these very small margins that we have today. So I think those are sort of that's the new laws of physics we're dealing with in terms of assessing these technologies. Some of which you're going to have them regardless of the costs. Some of which you're guaranteed to see the ROI. In terms of surprise ROI right now, I can't say that I'm really surprised, because we are going in with every AI tool that we implement. We are trying to solve a problem, but it may be the extent of the impact of that we've been surprised by. Now, with many of these things, you're trying to solve problems in the health system, and it's usually not the AI solution alone that is there solving the problem, right? It's, if you have a length of stay problem, you might be implementing some AI and a predictive model to try to drive care. Things that have surprised us is the amount that we've been able, the amount that we actually saw a bump in that was attributable to our, in terms of bumping our CMI using AI-based tools, in terms of additional diagnosis capture, that was a surprise to how big that number was for us as an organization. And the amount that we were able to impact potentially areas where we really were having issues. We had a pressure injury problem inside the organization that was facilitated by a predictive model. The amount that we were able to move that problem relatively quickly, in addition to downstream efforts from that predictive model, was very surprising to us as an organization, how quickly we were able to impact that metric, which is historically hard to move.
Okay, we're past the, we've got less than 15 minutes left, and I do have a couple really good questions in the Q&A that I want to get to. So I'm going to do that right now, and I'm going to stay with you on this one, Jim. It's something we've kind of skirted around and talked a little bit about, and I know we've talked about it in the masterminds as well. The idea that AI is replacing, well, the fear that AI is replacing jobs, that using AI is going to mean you're going to need less rev cycle management staff or whatever. You know, do you have a concern about the jobs that an AI agent will, in effect, eliminate? And how do you address that with your workforce? Will AI be taking away jobs?
So I think long term, we don't know the answer of exactly how much certain occupations are going to be impacted. But I do think that the writing is on the wall for certain roles, right? And that those roles will dramatically evolve, and we will need less people engaged in certain activities, right? You know, I do think, you know, probably the biggest example of that is coding, right? Agentic coding is proven. It's in certain domains. You know, so if you're doing radiology coding right now, you probably won't be doing radiology coding in the next 5 years, right? At least if you're coding every study, you may be doing quality assurance, you may be doing other things. So you know, as to, you know, whether or not you'll be, you know, whether or not you'll be making decisions regarding which medication you're going to write for patients, and is that going to be agentic? For simple medical decisions, I think we're further out on that time frame, right? You know, but I do think that we will get to the point where we're going to need fewer providers to take care of the same number of people. I guess the good news and the bad news is we have a huge provider shortage inside the American healthcare system right now, and we need to figure out how we're going to deal with that. So probably for at least the next 20 to 30 years, you know, even if we do introduce a bunch of AI that can take care of many of the simple things, our provider base is probably still going to be employed. But things are going to change. You know, there used to be a number of people every day that ran printing presses and did typesetting for newspapers, right? Those jobs don't exist anymore, right? And I think to say that things aren't going to change and certain occupations are not going to disappear is probably not an accurate statement. People will need to retrain, but there will be work for people to do. There's no doubt.
Okay, Zafar, same question. You know, we talk about AI replacing jobs. You know, how do you address that, and how do you feel that the workforce will change because of AI?
So I think there's definitely going to be a seismic shift, but the shift will be elimination of roles that nobody wanted to do in the first place, right? I mean, there's a whole bunch of tasks that people do on a daily basis that if you were to ask, is that something that, you know, really excites you? The answer would be no. So if we can use the AI tools to automate those functions or some of those very trivial back office admin roles, then those roles will absolutely in the future be gone. And you're seeing that, you know, in many industries. But Moving forwards, the question will be, what can the AI tools do to multiply the mission, right? How do you take 5 coders that are serving, I don't know, 500K outpatient appointments in terms of coding those episodes, and now the same number of people can do 1 million outpatient appointment coding episodes. So you're not hiring more people, therefore your costs are staying static, your volumes are going up, you're getting better patient satisfaction because people can get seen. So I think that's where the shift is going to happen. I don't think it's a straightforward model that you see from technology companies where they tend to come in and say, oh yeah, you can just get rid of 50 FTEs and it's just going to work. I think you have to be smart about what that shift is, where you're going to shift the workload between AI and human. And you'll always have to keep the human in the loop, right? Because somebody needs to check the AI. And I always say that, I'm a sci-fi person, so I always say, who's going to pull the plug if something goes wrong, right? What's that easy off button just in case?
Okay. All right, great. Thank you. Byron, same question.
Yeah, I'm thinking if I could offer something profoundly different. I think the realities are where the demand is far exceeding still the supply. Zafar's point, not everyone's working to top of license today. So, one of the promises is that we move people more closely to that. There is a lot of turnover in some of the roles that are most likely the first to, sort of be disrupted at scale by AI. But currently, we're just trying to keep up with demand, growth, looking for improvements, figuring out how to serve the provider and the patient, that relationship more effectively, and candidly looking at other opportunities, such as working with payers in the broader healthcare ecosystem. There's opportunities to work across, the lines, so to speak, in new and different ways, and offering up different models of care. So I don't know if it's AI precisely that will replace all jobs, or if it's just reinvention and transformation in healthcare is going to create just a new way of delivering care altogether. And there'll be different jobs, and hopefully more fulfilling and better ones at the end of the day than what we have. And I think that's kind of our goal is not just to kind of stay static and do what we do better in the same ways, but profoundly change the way that we do, and that'll create new opportunities. That's the optimist, the positive realist that in me that I think that future does exist out there ahead of us.
Good to be optimistic. That certainly is. 7 minutes left. One last question. It's coming from the audience from the Q&A, and I like this one as a kind of way to end this wonderful discussion we've had. And you may have noticed I had several other questions lined up too that I wanted to get to that I haven't had a chance. This is a topic that we could talk about all day long. The last question for each of you, with the 6.5 minutes we have left. Now that you've successfully deployed Agentic AI at scale, have you done that? What would you have done differently? And this is for, a lot of health systems out there just now getting into this. And with the hype and the speed that AI is being embraced, now that you've done it, what can you tell them about what to watch for right at the beginning? Something you would have done differently to make things better. Zafar, I'm going to start with you on this one.
I would say do your due diligence. It's very easy to buy into the hype. And there's a lot of, initially there was a lot of excitement and buzz. There's like over 1,000 AI companies, and they're all selling the dream. And it's very easy to fall into that dream trap. So I think you have to think about stakeholder engagement. What problem are you trying to solve? And then look at the technology stack, and not start with looking at the technology stack and being sucked into the rhetoric that creates. It goes back to the old, the old book of business, people, process, then technology versus the other way around.
Okay, Byron, same question. What would you have done differently?
Well, I think we did the important basics and foundational parts really well to begin with, to set ourselves up to get into this space early. We had internal teams that also allowed us to make better decisions when it comes to the ended product that we purchase. I will say that the thing that I feel is working well is it probably should just be a simple recognition, and that is to get the stakeholders involved very early and get product-oriented and design-led folks into solutioning very early, doing discovery work across the whole problem space. Again, so you're solving for the right problems and the right opportunities, and then try to find an agile partner, an agile platform to be able to iterate and prototype very quickly so that you can see whether or not you're getting leverage on said problem or opportunity. That's going to help retain engagement. It will help you scale efficiently. It'll cut some of the cost out up front. Some people, and we did this, initially, took probably too much of an engineering approach initially. It's really in the design and thinking through the product and the solution itself. And then you can pull in, sort of the engineering a little bit later to productionalize, make sure all the data mapping and everything is working. But you can get very far through prototypes. And so this is important with just AI, or especially, I think, agentic AI.
Nice. Okay, great. Jim, I'm giving you the last word on this one. What would you have done differently?
Yeah, I think knowing what we know now, we would have created more insistence that people really try and adopt these technologies. In 2023, 2024, it was a little harder to say you must try this, right? Because it is, we think it's going to make your life better. Or help you provide better care. Now the data is very strong, right? And we know that these technologies don't work for everyone, and so but I think the mantra of, I just like my practice the way it is. I don't want to try it, because I practice perfect medicine right now is probably a fallacy. And we want people. I think we can now say, look, we have an expectation that as an organization, you're going to at least try these technologies. And they may not work for you because some certain practices they don't, but we want you to be thinking about how you can use them. We went into this with a very voluntary approach, which I think when things were unknown, it was probably appropriate that you were taking a coalition of the willing. But now I would say that being a little more suggestive to folks that you need to, it's an expectation that you're going to be thinking about how to utilize these technologies is a reasonable approach to help improve your practice, because the benefits, not just to the provider, but also to patients, are becoming pretty obvious. And we really need to demonstrate and understand those use cases where people aren't, and particularly patients, aren't seeing benefits from the use of this technology.
We got about a minute and a half left. One really quick answer from all three of you. What's going to be the next biggest AI advance? What do you see on the horizon that's really going to make a difference that we should be aware of now? Jim?
I'm going to bank on non-language-based models, world models, are going to change, are going to enable an Agentic to go to the next level.
Okay. Zafar?
I'm going to say, as we unlock more and more data that we are sitting on top of, you're going to see a lot more intelligence in these AI agents.
Interesting. Okay. And Byron?
I think two things, and it's more probably how we do AI, and that is a lot more federated systems, federated learning systems, where the models come to the data and work through confidential compute and secure enclaves. But then also this year, you'll start to see that the patient themselves becomes a participant in the network, right? Of, denying or allowing, permitting their data to be used for various purposes. And so that'll become a thing that all of us probably have to address over the next year or two.
I like that you said that, because as we finish this one, in 10 minutes, our next AI Now presentation will be expanding opportunities for AI and patient engagement. That's where we're going next with the next panel. Thank you for all three of you for the time today, for this wonderful conversation. In closing, please note that if you registered for that next panel, a live clickable link will appear at the close of this session to take you directly over to that program. And I'm jumping over there too in a minute. If you've not registered for the program and wish to attend, you've got a few minutes. You'll need to click on that link and fill out the registration to gain access. I want to thank all three of our panelists here today. As I said, a wonderful discussion. We could have gone on for a lot longer. Special thanks to those of you in the audience for participating today. We hope you enjoyed this session. We hope you jump on to the next one, and that you join HealthLeaders for other events in the near future. Thank you very much.
Thank you.
Sure,
Thank
thank
you.
you.